So following Dr. Mufti's talk, I thought I would focus on acute myeloid leukemia, AML, and talk about the molecular alterations in AML and how they may be changing our clinical practice of this disease. So thank you so much for the opportunity to be here. So as most of you know, AML is a clonal stem cell disorder characterized by somatic cytogenetic abnormalities and molecular genetic abnormalities. And these are established in their use in the diagnosis of the disease and determining prognosis at the time of diagnosis, and hopefully, ideally, as therapeutic targets, but that's lagged further behind. So we'll focus on these three issues today. So as all of you know, cytogenetic abnormalities are very well established in both diagnosis but also prognostication in AML. And they fall into three categories in terms of prognosis: those that are favorable, those that confer adverse prognosis, and those that are intermediate. The favorable being the core binding factor alterations, translocation 821, inversion 16 or translocation 1616, and the PML-RARA translocation, whereas adverse being the ones listed here. But I think, as many of you know as well, at least half of patients with AML actually have no cytogenetic abnormality or no abnormality that falls into favorable or adverse categories. And for these patients, the use of further molecular genetic monitoring has helped move them into more favorable adverse category, with particularly the FLT3-ITD mutation present in normal karyotype AML commonly and making the prognosis a little bit worse, whereas those patients that are NPM1 mutant or have biallelic CBP alpha mutations kind of improve the prognosis to favorable. But even still, with everything we have on this screen right now, a significant proportion of AML patients actually have none of the above cytogenetic or molecular genetic abnormalities. And there's a lot of heterogeneity within each of these categories as well. And so over the last 5 years or so, I think a lot of what Dr. Mufti talked about has also happened in AML. There have been a number of new molecular genetic alterations discovered in patients with AML, some of which are almost as common as the FLT3 mutation. Mutations, for example, in DNMT3A, IDH1, IDH2, and the others listed here, many of which are also seen to some degree in myelodysplastic syndromes. And so the question really is, what is the clinical relevance of these alterations for patients with AML? And that's what we'll talk about moving forward. So we'll cover first prognostic value at diagnosis of these molecular genetic alterations, and then very interesting and very promising new data about their use for minimal residual disease monitoring and turning prognosis after the start of therapy, and also what they can mean for treatment decisions. So this is a histogram of mutations in AML that comes from the Cancer Genome Atlas, published a couple years ago. And so what you can see is mutations in FLT3, NPM1, and DNMT3A are all very common in AML. And at the moment now, everything shown here in red is a significantly mutated gene in AML that's actually not accounted for in our most up-to-date WHO classification of AML. So there are a lot of genetic alterations to AML that are common, which we don't think about clinically at the moment, at least in our guidelines for how to think about AML patients. So what is the clinical relevance of these alterations? It's not a simple question. This is an example of the difficulty. This is 3 studies published all in 2010, looking at just one molecular genetic alteration that's new in AML, which is IDH1 mutations. These are 3 different studies, all in normal karyotype AML, and what you can see here is they actually had different results. This study showed that IDH1 mutations were conferred adverse prognosis in normal karyotype AML, whereas these other 2 studies did not find the same results. They were all large, at least 200 patients each, but I think there are a lot of differences between them. The first is the treatments administered between the 3 studies was different. The study populations were also very different. So in order to kind of improve upon this, several years ago, when I was still a member of Ross Levine's laboratory at Sloan Kettering, we performed a study of a very uniform AML cohort that came from the Eastern Cooperative Oncology Group in the United States. This was about 350 patients with AML, all between the ages of 16 and 60, that were randomized to either high-dose daunorubicin chemotherapy, 90 milligrams per meter squared daunorubicin, or standard dose. And we sequenced 18 genes that were known to be commonly mutated in AML in this cohort to try to understand what their prognostic value was. And we'll go through that data here. It's old now, published several years ago, but I think still important, and also a nice contrast to very recent studies looking at MRD in AML. So what we found was that about a third of the patients in this cohort were mutant for FLT3, but also DNMT3 and MPM were very common. And I just show this figure. These are sort of plots we put in this paper, which are so-called Circos plots, looking at the frequency of different genes that are mutated. And what you can see is these bands connect commonly co-occurring mutations. And the basic take-home point of this figure is that AML is very complicated. Many mutations coexist within the same patient, and that'll be a theme going forward. So do these mutations have prognostic value, and can they refine our ability to risk stratify patients with AML? So we'll first look at the overall cohort of these patients, regardless of cytogenetics, and look at those that confer favorable versus unfavorable outcome. We'll then focus on the cytogenetically defined intermediate risk AML patients, and also look at those that are FLT3 wild type specifically. So if we look at the overall cohort of these patients with AML, there were four mutations that were associated with adverse outcome regardless of cytogenetics. One was FLT3 mutations, which are known to confer adverse outcome, also MLL partial tandem duplications, but also two mutations in new genes, ASXL1 and PHF6, which although rare in this young AML cohort, were associated with adverse outcome. In contrast, there was one mutation, regardless of cytogenetics, associated with favorable outcome, which is IDH2 R140Q mutations. And this is a little bit controversial, this data, in terms of other studies more recently I don't think have seen this, but it was certainly true in this cohort, were associated with favorable outcome regardless of cytogenetics. Now looking just at those patients with intermediate risk AML, we see here those mutations associated with adverse outcome again include FLT3, MLL, ASXL1, and PHF6, but also now TET2 mutations were associated with adverse outcome, and IDH and CEP alpha mutations associated with favorable outcome in intermediate risk AML. And if we look at those that are FLT3 wild type with intermediate risk AML, we're seeing here that there are a subset of patients that have mutations commonly in NPM1 and also IDH. They were so-called NPM IDH double mutant, which actually have a very good outcome, much better than other normal karyotype AML patients without the FLT3 mutation. And this was one of the interesting findings of this study. So if we look at this cohort then, those with intermediate risk AML that are FLT3 wild type, they actually are very heterogeneous, and there are those that have outcome all the way up here, which are double mutant for NPM and IDH, and in contrast, those that have much worse outcome down here that have mutations in one of the four genes listed here. So even within patients that are intermediate risk, cytogenetically normal without the FLT3, we can find a wide heterogeneity in outcome based on further molecular analysis. If we look at those that are normal karyotype that have the FLT3 mutation, we also see some heterogeneity in the outcome. It's not as wide as before, with those patients that are CEP alpha mutant being a little bit better in their outcome, whereas those with mutations in TET2 or DNMT3, etc., down here. So we can discriminate patients that have further change in prognosis based on additional molecular mutations. So to take the main conclusion really from this data is summarized here. If we use cytogenetics alone, FLT3, NPM1, and CEP alpha, the patients from this cohort fall on one of three curves as listed here. If you add in further molecular profiling, we can discriminate patients which normally we would find to be on this curve, but instead could be all the way up here or down here. There are those that have intermediate risk cytogenetics with favorable mutational risk, and their outcome can even be superior to those that have otherwise favorable cytogenetics. In contrast, there are some patients who are intermediate risk and FLT3 wild type, but their outcome is actually just as bad as if they had unfavorable cytogenetics based on further mutational analysis. So we had proposed at that time this sort of system where based on cytogenetics, patients are placed into either good, intermediate, or adverse groups, and then further based on FLT3 ITD mutational status, patients then are grouped into groups overall prognosis being favorable if they're NPM IDH mutant, or unfavorable if they have one of these further mutations here. Now, I think overall this sort of scheme is probably not very practical, and I'll get into why that is in just a minute. And I think there are actually probably going to be more promising ways to prognosticate patients with AML than using this complicated schema. But at the time that we published this, it was sort of the state of the art. And so the other point here is that based on cytogenetics alone, at least half of patients with AML fall into this intermediate risk cohort, but using further mutational analysis, we can shrink this cohort and increase those that are favorable or unfavorable based on further mutational analysis. And that was one of the take-home points. But again, this is complicated, and I think there have been more promising techniques that have come out since. And this is a study I'll highlight to this point, just came out very recently from the group in the UK, the MRC group. Very interesting study, which suggests that actually following mutations over time may be more prognostically robust and simpler than this complicated multi-gene panel sequencing effort. So this study was suggesting that the presence of mutations at minimal residual disease, based on detection in this case of mutant NPM1, predicts relapse and is superior to the baseline diagnostic molecular genetic markers. So this was a study from the UK MRC, NRCI AML 17 clinical trial, 346 AML patients, all of which who had the NPM1 mutation. They sequenced 51 genes at diagnosis in 223 of the patients, but also did QRT-PCR for mutant NPM1 in the peripheral blood at diagnosis and at the time of morphologic minimal residual disease. And what they found is the following. The first is this is the molecular data. So all the patients are NPM1 mutant, as shown here, and there are many co-occurring mutations and all sort of complex patterns. And the point here is that there are more than 20 mutations that commonly co-occur with NPM1. So if we ever hope to use the mutations at baseline for diagnosis, it's going to be too complicated. There are too many groups. It's too much to make sense of. Instead, if you look at the following, the mutations that co-occur in DNMT and FLT3 and NPM1, they have prognostic value, but even more promising, the presence of minimal residual disease based on mutant NPM1 detection at the time of morphologic remission is very, very strongly prognostic in terms of relapse risk and risk of death. And this is even stronger than looking at co-occurring mutations with adverse outcome. So the point here is that looking at minimal residual detection for NPM mutations is much more robust than looking at co-occurring mutations to predict relapse and risk of death. This is that point further. So these are curves from that paper looking at survival and relapse risk based on MRD status. Those patients that are MRD positive have a worse survival and higher chance of relapse than those that are MRD negative. If you look at those patients that are even FLT3 wild type, so these are NPM1 mutant, FLT3 wild type, normal karyotype AML patients. These are patients that clinically right now we might think actually have a very good risk, and we may not even recommend them for transplant. But if they are MRD positive, even though they don't have FLT3 mutation, they are at a higher risk of relapse. So just by following NPM1 mutational status, this may be very useful for predicting relapse and risk of death. So I think hopefully I've shown you so far mutational profiling has been used to improve risk stratification of AML and also provide a biomarker that will predict relapse. But there are many questions related to MRD still. First, similar to Dr. Mufti talked about for MDS, should we be using peripheral blood or bone marrow for MRD detection? This is a question that still needs to be addressed. What time points should we use? That study looked at the time of morphologic remission following induction chemotherapy. Should be the standard time point or not? What about patients who don't have NPM1? We know, Dr. Mufti mentioned at the end of his talk, mutations in DNMT3A and TET2 are associated with clonal hematopoiesis in many patients without overt clinical disease. Maybe if we followed these, they actually would not predict relapse or survival like NPM1 does. So that needs to be understood further. And how does MRD monitoring with molecular techniques compare to flow cytometry-based MRD detection? This needs to be systematically addressed still as well. And then most importantly, what about treatment? So I'll just mention, again, going back to the ECOG study that we had published, this study looked at high dose versus standard dose induction chemotherapy for AML. And so we wanted to understand, are any mutations associated with improved response or decreased response to high dose induction chemotherapy? And what we had seen in that study at the time is that there are only patients that are mutated for DNMT3A, MLL, NPM1 actually responded to high dose induction chemotherapy. If you didn't have any of these mutations, it actually didn't matter whether or not you got 90 milligrams or 45 milligrams of daunorubicin at induction chemotherapy. So this suggested that the mutations detected at time of diagnosis actually will predict for responsiveness to induction chemotherapy. So how do we actually introduce this into clinical practice? Because as you know, if you see a patient with AML, you have a limited period of time to detect mutations before you can start your treatments. So I thought I would just share with you very briefly what we do at our center. So currently at Memorial Sloan Kettering, For any patient that we have with a new diagnosis of AML or relapsed AML, we perform targeted analysis for FLT3, IDH1, IDH2, and targeted tests for BCR-ABL and PML-RARA translocations to return this test result ideally within 72 hours. And we do this on every new and relapsed AML. And we also, of course, do cytogenetics in FISH. We also send a more extended panel, and this returns about a week later for further molecular alterations that have prognostic relevance in MDS as well as AML. If we find patients, and there are rare patients where we don't know what to do clinically or don't have any of these alterations, we also will send a much more extended panel, which is about 400 or 500 gene testing, and this one is actually commercially available anywhere in the world right now, and tests for 400 genes, and also RNA-seq analysis to give us some clue of what may be happening with the patient. And the reason we do this is we have the following clinical trials right now available for AML patients at our center. Only 2 studies we have open for newly diagnosed AML patients, and they're based on molecular alterations. One is newly diagnosed AML patients with the FLT3 ITD mutation, which combines the FLT3 inhibitor clonolnib with 7+3 chemotherapy. In order to enroll in this study, you must have a FLT3 mutation, so therefore we have to be able to diagnose the presence of the FLT3 mutation in a very short period of time, which is why we check at initial presentation. We also now have a study combining the IDH2 mutant selective inhibitor AG221 with 7+3 induction. And again, in order to enroll in the study, you must have an IDH2 mutation. So we check this routinely on every patient referred with a diagnosis of active AML at our center with the hope of trying to enroll them on this study. The rest of the studies we have available are all for relapsed refractory AML, and some of them, most of which we're focusing on mutant IDH inhibition, which we think is very promising right now for AML patients. The other studies as listed here actually have no molecular alteration that they're targeting, and so it actually doesn't matter what the mutational status is to enroll in these studies. And I'll just share you, second to last slide here. This is a slide of data from the US study of the mutant IDH2 selective inhibitor AG221. This is an oral drug. It's used as a single agent for relapsed refractory AML. And also MDS is allowed to enroll on this. And this is our swimmer's plot of the patients enrolled up to this time point. This was presented at EHA last year by Courtney DiNardo, MD Anderson. And what has been seen so far in this study is that in a relapsed refractory MDS AML cohort, about a 40% overall response rate with single agent IDH2 mutant selective inhibition, which I think is very promising. And now the study is in the dose expansion phase, which is ongoing still. In addition to that, we have this upfront study combined with 7+3 induction chemotherapy, which I think will hopefully be very promising as well. So to conclude, what we've shown, majority of this talk is comprehensive mutational analysis, has importance in AML in terms of identifying disease risk and use in MRD monitoring, which I think is very, very promising and may be more practically useful than determining disease risk at diagnosis. There is hope still that identifying these mutations will provide new targets for novel therapies, and the IDH is just one, hopefully just one example of that. But the genetic complexity of AML makes prediction of outcome based on mutations at diagnosis difficult. And as you've seen, there are lots of co-occurring mutations and many patterns of mutations. And so I think it'll be very difficult to really robustly predict diagnosis based on that alone at diagnosis. And we think assessment of relapse risk and survival may be simplified by the use of MRD monitoring at morphologic remission. And this will be very important to standardize going forward throughout the world. There's also still a very great need to improve outcomes and study genetic alterations in elderly AMLs. Almost everything I've shown in this talk was a study in patients less than age 60 with AML, and so there's still a great need to improve outcomes and understand those with AML in their elderly age. So with that, I'll stop. I want to thank my colleagues at Sloan Kettering, particularly my prior mentor, Ross Levine, and others in the group there, and our clinical boss, Dr. Tallman, and others that participated in some of the work I've shown you. So thanks for your attention.